Welcome, everyone, to Beauty and the Surgeon podcast. I'm Amy. I'm a nutritional therapy practitioner, and I'm joined today, as always, by my very jolly co-host, Dr. Jason Martin. He's a board-certified plastic and reconstructive surgeon. Dr. Martin, it's December.
Oh, I can't wait.
Very jolly month. I can't believe the year is almost over, which means that the next episode that comes out after this is our top 5.
Right.
Which is always my favorite episode of the year.
Which means I have to start preparing, which I never do. It's always too late.
If you are not subscribed, I highly recommend subscribing and turning on notifications so that you get notified when we release new episodes, because our top 5 is by far my favorite episode of the entire year.
It is fun.
Yep. And there's always a compilation that Nils does.
Nils
that
does
is
the mashup
always the best.
The best.
Watch the Nils mashup. They are fantastic. And also, if you want to find any of our social medias, you can find those linked here. You can also send me a voicemail or send me a text at 303-630-9038, because this episode, listeners, is all about you. So I called it listener questions, but it's a little bit of both. So it's a little bit of listener questions, but we also have some listener updates.
Nice.
So people who left questions on our previous questions episode sent me back more information and some additional questions and other things. And so I'm just super excited to get into all of that, but we could not do it without you. So thank you all so much for being here. And without further ado, should we get into this?
Let's go.
We should do the do. All right. So our first one is an email that was sent from Elizabeth, and she said, why are umbilical float tummy tucks so unpopular? Once you have one, can it be converted to a full tummy tuck? This was such a great question.
Very good question. Number one, I don't think they're unpopular. I think that floating the belly button, which we'll describe in a second, maybe Amy can help us with that, is a great way to do a mini tummy tuck or a short.
If you have the right body type.
Right. I was going to get to that. That's why it's maybe not as popular. To do a short incision tummy tuck, you divide the stalk of the belly button and you can do a diastasis repair the whole way without extending the incision out to do a full tummy tuck and keeping the belly button maintained on its native stalk that you're born with. So,
but it means that your belly button will be slightly lower after surgery, which if you already have a low belly button.
So basically, this is the presentation that it works for, and it's not common that people come in. You have to be pretty darn good above the belly button. You have to have some looseness below the belly button. Your belly button preferably is high riding, okay?
And not terribly distorted.
Right. So it means that your belly button's not super low, which a lot of people come in and they have low belly buttons. So it's higher up.
Yeah,
and that
pregnancy
can
kind of lets it drop.
But sometimes pregnancy can result in it being higher.
Yeah, because they have fat below.
Yeah. So it just depends on your presentation. And then preferably, if you're going to divide the stalk, then you're going to do a diastasis repair. So you got to present with a rectus diastasis or a splitting of the muscle. That's a lot of check marks you have to go through to be a good candidate for this. So I don't think it's unpopular, Elizabeth.
It's just not for everybody.
Right. Can it be converted to a full tummy tuck? This is such a tricky question. I feel like Elizabeth is part of the plastic surgery board examiners. I mean, come on, are you trying to trap me in this question? So probably it wouldn't be recommended. Theoretically, you could do it because technically at that point, the umbilicus would be a skin graft on your abdominal wall, which is the way you sew it down and it kind of adheres there. So I think it's possible you could do it. I think that the plastic surgeon you go to would have some trepidation about it, but I think it's possible.
Yeah, I mean, I think the risk there would be that you would have a loss of the belly button. You'd have to kind of recreate one in a way that didn't look very natural.
Belly buttons have a stalk, and we know this because if you've seen a baby, when you divide the umbilical cord, that stalk is really goes down into their belly area underneath the skin.
Keeps it attached to the muscle wall.
And as you go on in life, you actually have blood vessels that go through that stalk that feed your belly button. So when you divide it, basically you're bringing the blood supply to your belly button is coming from the surrounding tissue. So, and you sew it down when you float the umbilicus. So when you go back and divide around the umbilicus secondarily, then you're kind of dividing that blood flow to the umbilicus itself.
Yeah.
You'd have to wait a long time.
Yeah.
It'd have to be years.
And you'd have to need another tummy tuck. You'd have to have more laxity form, which would ultimately mean that you either had restretching of the abdominal wall or restretching of that skin or gained a lot of weight or had another pregnancy.
I love these questions because it's kind of like we're sleuths. Because is Elizabeth thinking about it? Did she have a floating of her umbilicus and
now
she
wants
went
a full?
Full? Yeah, I mean, it's possible.
Because that is something we say in our tummy tuck episodes. Like for most people, a tummy tuck is a one and done. If you maintain your weight, once that skin's gone, it's gone. It's like somebody who unless something changes that caused those same changes to happen to your abdomen again, age doesn't tend to cause that type of need.
But she could have been heavier. She could have done a mini tummy tuck with floating in the umbilicus. She could have lost a lot of weight and
but that's
aged.
what I mean. Something happened.
Something happened.
Yeah.
And then had to come back and now has redundancy of skin and soft tissue and wants to do a full tummy tuck.
And we've done revision tummy tucks, and it is in those cases. That's why I caveated that with if you maintain your weight.
Elizabeth, I will say, I think it's possible. And if you need it, even if the leftover belly button after you incise around it has some issues, it still would heal down. And I think it might be worth it. So I think you should consider it. But I think the plastic surgeons are going to have some trepidation for sure.
Definitely. But this was such a great question.
What a great question. Super smart. Why are these listeners so smart?
I know. In just 2 sentences, asked such a great question.
Like Nils now knows everything about plastic surgery, and he's a dude.
It's because they listen.
That likes comedy and dogs. So
this next one is a long one, and that's why I have my iPad here, because I'm going to, if you will bear with me, Dr. Martin, because
you're going to read this whole thing?
I'm going to read most of it because you kind of need it. So this was a follow-up. So we have 2 different listeners named Nina who both sent me follow-up emails, which was crazy. So this is from the first Nina. Let me make sure I'm reading the right one. Okay. Follow up from Nina. Wanted to thank you and Dr. Martin for creating such a wonderful podcast. It has helped me tremendously.
Nice.
I really like the mixture of education and advice, the powerful, your favorite word, stories of transition, I think she means transformation.
Yeah, that's right.
As well as just normalizing plastic surgery in general, which is what we try to do.
Thank you, Nina. Thank you.
I have suffered from big breasts my whole life. They've always been in the way. They weigh me down. They don't fit my lifestyle. They've never really felt like me. This is the person who asked about if it's normal to be nervous before surgery. I'm also bringing a bit of anxiety and OCD into the mix. I'm afraid of surgery, maybe even more than the normal person walking into a plastic surgeon's office. So afraid that she wouldn't even consider surgery until about 2 years ago. Now she's faced her fears, researched surgeons, found a great team. It's actually 2 doctors. They operate together, shortens the time.
Tag team.
Makes her feel more secure. But here's her question. How do I truly prepare mentally for the surgery? What can I do in the months leading up to it? What can I do on that day? What in the moments leading up to anesthesia? And what are the things that I definitely shouldn't be doing? Such great questions. I was just wondering if you also have the protocol that you could suggest for me. How do I shepherd myself through this very draining emotional time? I have intrusive thoughts that I will die, which I know are only thoughts and not facts, but it's still draining. Do you guys have any experience with patients being really afraid? I'm practicing relaxation every day. I do yoga and meditation, some hypnosis and journaling, but I wondered if you had special tips. I have become a surgery research machine, as my partner said.
Loving Nina.
And I know a lot, but I'm still scared of the emotional
I know
toll.
her partner's probably so over it, but I love Nina. I love research machines.
Sorry if the question was so long. I wasn't sure what you needed for context. And then she said, P.S. In one of the episodes, you mentioned that you have a handout for nutrition before and after surgery. Is it possible to download it somewhere? Thank you so much. So Nina, yes, I will send you my PowerPoint presentation on recovery and nutrition. In the meantime, Dr. Martin, this was so great. So she's doing all the things. She's meditating. She journals. What would you say if this was our patient? What could she do in those, specifically like in the moments when she's getting ready to go to the surgery center, day of, like the day of stuff?
Well, first and foremost, I mean, I think you're better at some of this emotional intelligence stuff, but I will say that for me, and the way my brain works and most of our patients, empowerment comes from education.
Mm-hmm. Which she isn't. What did she say? Research machine.
Yeah. So I think when you have intrusive thoughts, is to always go back to that, which is, okay, let me go through this data again. Let me look at this stuff. Am I missing something? Yeah, obviously it's more like, I mean, in religion, they do like repeating words and things like that. It is meditation, but
it's the surgical rosary.
Yeah, exactly. I was about to say that. I didn't want to bring Catholicism into it, but it has that component to it too. It's going back to that repetition of looking at things.
You make me a nun when I say that, Nils.
So when I you as a nun, just
I know it's
with a big habit.
With the habit, yeah.
So when I was starting out, I'm a very fastidious person. I'm mercurial sometimes. Amy has to deal with that. And I'm very driven. And I come from the inside. I have a creative type. I'm not someone who just can grab it from the outside and impart it on me. It's more about inspiration. And when I was starting out, there was a lot of anxiety. Not anxiety is not the right word. Well, maybe it was anxious. I was anxious. Maybe not anxiety. And I would always go back to the surgical plan. Amy brought this up the other day. I would draw things out.
Mm-hmm. And I loved it.
That's the way I would calm my brain. Okay.
Well, that really helped me learn too.
Right. And so I think that element of doing the research stuff is really important, first and foremost. So that's kind of leading up to it. The day of, I'm not sure if you need to go through your notes on your notes. The day of, a lot of times, or the day before, a lot of times people that truly are having anxiety, we'll suggest that they take a Valium or not.
Or they'll prescribe it so that you get it when you get to, because you have to sign your consents again.
Right.
So you don't want to take it before you get to the surgery center.
I'm talking about the night before.
Oh yeah, the night before. Yes. Yeah. Valium the night before.
Take a Valium the night before. I think that's really, really helpful because that can allow you to sleep a bit. You're not going to sleep great, but allow you to sleep a little bit. And then when you wake up, at the very least, you're not like full on anxiety brain.
Well, and you've gotten to sleep. Like that helps so much. Like being sleep deprived makes no one's anxiety better.
Right. Day of, I think probably what's going to make you feel the most stable, basically, or confident is seeing your surgeons, seeing their face, having them talk to you again. This is the plan. This is what we're going to do, and go from there.
Yeah.
When it comes to breast reduction, it's a very routine surgery. There's a very low risk of complications and competent hands. And there's a very high likelihood of extreme happiness afterwards in terms of your results.
The most happy. Yes, which she knows from listening to our podcast episodes. Like she knows. Like so she's going to be happy with the results.
The other thing that we tell patients all the time is like focusing on the North Star. And with breast reduction, it really is a change in your quality of life. Like there's not many surgeries that offer that, a quality of life improvement, and breast reduction does that. And that's, I think, kind of where your focus should be. It's like the goal.
Not having felt like yourself. Yeah. Can I?
Oh, please. Yeah. I mean,
I don't want to interrupt you.
I'm like, you're the one who's better at this kind of stuff than I am.
Well, I mean, I think about it this way, Nina. Because I compete in bodybuilding competitions, and when you're up on stage wearing about 0.5 centimeter of fabric, being judged on your physique, there's people and there's lights and there's all these things like that can be something that causes a lot of anxiety for a lot of people. So for me, I don't tend to be anxious about it, but what I do to kind of prevent that feeling is I literally just go through it in my head. So specifically for your day of concerns, like I would go see if you can do a tour of the surgery center prior. All hospitals. I mean, it's like when you have a baby, like you go do an orientation at the hospital or the surgery center.
Smart, yeah.
Then you'll have seen the OR, so it's not going to feel
foreign,
new.
Yeah.
So and then you can picture it. Like this is where I'll be taken, before I go into surgery. This is where the doctor is going to mark on me. Like this is what the pre-op looks like. This is what the OR looks like. This is what the recovery looks like. So then you can kind of go through those in your head. And you can just visualize it. I think visualization is so powerful. And you already said you do things like hypnosis and yoga and some journaling. But I think that adding that in, that visualization of just what is going to happen the day of, and that's it. And it's normal. I mean, these are normal things to think about. So I think not judging yourself for feeling these things is also something like just let go of the judgment around them.
Yeah.
Like you do when you meditate. Like it's just like clouds passing through the sky. Like, this is fine. Like, it is okay for me to feel this. And I think that, like, giving those fears a place to be heard.
Yeah.
Like, okay, fine. This is a fear. It's a legitimate fear.
That's totally
But I
reasonable.
can't control it.
Right.
So let's just let it go.
Going to surgery and going to sleep is like going on a plane. You have no control over anything. So...
Well, you have way more control in surgery. You got to pick your surgeon. You're getting elective surgery.
Right. You didn't get to pick that would be awesome. If you could pick your pilot.
Or your plane.
Oh, I'd definitely take that airline. It would be like you look at their, what do you call that? The
their
digital,
CV?
Their avatar. You look at their avatar, spin it around, see what their
Can we
stats
see when
are.
this plane had its last checkup? Like, what do you mean the wing doesn't work?
Night? Can I look at that real quick?
When was this engine changed?
So, when I see my patients, I want to impart to them that I'm extremely confident, and not because of hubris or to coerce them into something, so they understand that I am here clear-headed and ready to go. And I can tell you in almost all cases, you feel this sense of relief and just a human experience.
Well, it's someone like you don't know your nurse maybe, but you know your doctors, and you've got 2 of them. So it's like doubly confident.
Yeah, it's double the fun.
Yeah.
Yes.
Yep.
Anyways, but as I think the other part of it is anxiety is normal around surgery. If you already struggle from anxiety in your life, clearly you're going to have more of that around the time of surgery. You're not going to be able to stop that feeling because that is just universal. People have anxiety, trepidation, concerns, fears, and that kind of stuff. Having very strong thoughts that are pretty harsh are always mitigated by looking at the data, looking at real information. And hopefully this podcast is one of them for you, but if you can find that from your doctor's office on the internet and from us, I think that's really, really important. Just keep going back to that. That's what I do in my career. So.
Yeah. And after surgery, I mean, this is again going back to like to competing. The first time I competed, my coach does a podcast, and the day of my first show, I just listened to his podcast, like just hearing his voice, like listening, like just it calmed me down. So like having something maybe that you've recorded, you can put your little headphones in when you're sitting back there, because there is some time where you're just gonna be chilling, you know, like waiting for your doctor to come in and mark you, waiting for anesthesia to come in. You know, you'll be at the surgery center for a couple hours before your surgery even starts. So having that, you know, throw your little earbud in, zone out, listen to something calming. And the same thing after surgery. You've listened to our podcast. You know, recovery can be a little bit of a mind game, like listening to those things that calm you down, listening to us talk about recovery, or talk about how awesome people's results are. Like those are things that are going to help you get through those first couple days that could be emotional, but let your partner support you too, you know, and just trust that it's going to be okay.
I don't know if I would listen to my voice for recovery. I would definitely listen to Amy's. It's kind of soothing. Yeah. It's kind of a soothing voice. You know, for me in surgery, this is really weird. And it's kind of been this way since the beginning. I guess there was a year about kind of ramping up, but when things kind of hit the fan, I get more calm rather than less. Mm-hmm. And I've always kind of been that way. It's weird. And
you're like the eye of the hurricane.
Yeah. I feel
you're the calm in the storm.
Things kind of come in and I feel super focused, and things kind of slow down for me. And sometimes I don't realize I'm doing that, right? Because plastic surgery, for Nina's purposes, you're going to be fine. There's rare as anything.
It's controlled surgery.
Rare as anything that's going to go on. It's an elective surgery, but
it's
even
not like a car crash.
Things that
coming in
require a little more input, quick kind of reflexes, I tend to calm down, and that's just kind of the way I was made up. So I think that accepting who you are is a really big part of you know, going to do elective surgery, because you have to accept your limitations, and then allows you to have, you know, appropriate expectations and allows you to recover well. So I love this. I would never read this whole thing because I don't have the attention span for it.
Which is why I read it.
Yeah, thank you.
Yes. Yeah. So
she's awesome.
And just, I mean, we always say the best patients are the ones that are educated and empowered. So research machine Nina should do great.
Yeah,
exactly.
She should.
Yep.
Should share some notes, man. We'll do an episode on Nina's notes.
Yeah. So Nina, thank you so much. That was amazing. And this is a follow-up from a different Nina. I was like, am I seeing this correctly?
And they're like the same amount of words.
Totally different topics though. Like could not be more different topics. So this is amazing. So this is the Nina who left the question about the saphenous vein question. Like, do you remove it? Does it die? And we're just going to call it the SV so I don't have to say it 1,000 times. So, hello, my favorite lovely surgeon on YouTube. Never boring, always entertaining, and more importantly, very informative. I am a 60-year-old. I sought out a fully qualified plastic surgeon for a solution to a botched liposuction I had on my thighs. Had a fat distribution, had fat transfer to her face, turned out good underneath the eyes, cheeks didn't, other areas didn't take. Hard to describe all the botched areas without seeing the legs. She had vasor under her thighs. Well, now the skin is loose. So the solution...
Thigh lift,
right? The day came, she had a consult, found out about the SV, and the only reason she brought it up was she had ultrasound on her legs to check for any blocked veins, and it was all good. So they checked it. So that's why she brought up the vein in general.
Right.
Well, so he, that's why they talked about it. Well, so in the meantime, we released our episode.
Yeah.
So she sent...
So I knew there was an extra layer to this.
This is why. So she sent an email to this doctor's staff with our podcast, with a link near the 17-minute mark to listen to your answer to her question. Like, if we remove it, does it die? Asked if he'd listen. He said he didn't listen to other people's podcasts. She wrote maybe or maybe not.
He didn't listen.
He did not. Anyway, I wanted to share with him what you said. He told me it's through the liposuction when the vein gets damaged and ends up dying. So... She asked.
No, so now I get this. So what he was saying was the previous liposuction, he wanted to see if it was still patent, right?
No, she did the ultrasound on her own. Okay. Like that was unrelated. So she said
But he was referring to the previous liposuction that it could have died.
No, he's telling her it could die now with the thigh lift. Yeah. She said, how do you try to preserve the vein? He said, because we said, you try to preserve it. And he said, that's what we say, but that we can't say that it's never happened to us, that it's died.
Right. No, that's fair. That's fair
enough.
That's fair.
I guess that's fair enough. But we don't actually remove it on purpose.
Yeah.
Anyway, he ended up saying that he didn't think she should do surgery because she could get lymphedema and have persistent swelling, and that, basically he refunded her. So he said he doesn't do many thigh lifts and that she should find someone who does.
Okay.
He
fair.
also said that she'd need,
It's a reputable surgeon.
yeah, that she'd probably end up with lymphedema and that she'd need to wear stockings every day.
Now,
Her
just
legs
real
would feel
quick,
heavy.
Like lymphedema, I just have to say this. And again, we're not getting maybe all the information, but lymphedema is different than swelling from not having competent veins.
Yes.
Okay.
Yep.
And you can do thigh lifts, and a high majority of those will not cause lymphedema if you have normal lymphatic drainage.
Correct. And that's unrelated to the vein. That's more about the lymph system.
Right.
So either way, he told her she'd have to wear stockings for every day for the rest of her life. Her legs feel heavy. Find another surgeon. So she found another surgeon, which is awesome.
Yes.
So she's
What
going.
did this guy say, or lady?
Well, so she hasn't had it yet. So
Oh, no,
this was the update. So
we have to get another update from Nina.
So yes, Nina. So we love the update. I love that you sent another doctor our
We should
podcast.
just start doing video consults on here on the podcast with Nina just to see what she could tell us exactly what happened.
But I think this is important. And she said she was disappointed. She'd already paid her deposit, which they did refund. She was like all ready for surgery. But I think that the salient thing here that happened with all of this is that this doctor really wasn't comfortable doing this surgery. And the fact that he told you that
It's great.
is amazing, regardless of
Kudos to
whatever
that
other
guy.
things he said.
Yeah.
Not doing the surgery was the right decision. And I'm glad that however you guys got there, you got there.
Right.
And that I hope you love the new surgeon that you're seeing.
Yeah, yeah. And that's wonderful that surgeon was honest with you.
Yes.
So, and it's not a science, it's an art form.
Mm-hmm.
That surgeon may have seen something on Nina's exam that was really concerning to him. Maybe she does have pitting edema, maybe she does have a presentation that's concerning. Maybe there's something in Nina's past medical history that would concern him for the future, or concern the surgeon for the future. So
yeah,
honesty is the best policy in this. If you have concerns, or if you think that there might be a risk of X, you need to tell the patient. I've said that before from a position of strength, like I really felt that way, but the patients were like, I'm not really sure about this. I'm like, please get another consult. Talk to someone else. Maybe they feel differently. Because when those things are in the gray area, you've already had surgery before, it was quote unquote botched. Maybe a part of this, the surgeon didn't feel like the thigh lift would solve all your problems. Maybe there's a little part of this, he thought that the expectation game couldn't be met.
Well, and if he doesn't do a lot of thigh lifts and you have had previous surgery in an area, anytime you're doing surgery to revise a previous surgery, it's going to be more challenging. So if he baseline doesn't do a lot of thigh lifts, he probably doesn't do a lot of revision thigh lifts. I mean, again, him telling her was the right thing.
Yeah, I love it.
Yeah. So Nina, thank you so much for the update. And I now understand where that question came from, because when it came in initially, I'm like, whoa, this is a question we've never gotten before, and it's going to blow your mind.
Great question.
Yeah.
I love the fact she got an ultrasound afterwards.
No, she got the ultrasound before.
Oh, okay.
This all happened before the consult. She had the ultrasound.
I thought she had it afterwards. So that would be.
No.
I like that.
Yeah.
Like the guy's like, well, I don't know about your saphenous vein. She goes, well, I'm going to ultrasound it.
Well, that's how she knew about it. Yeah. So love it, Nina. Both Ninas. Thank you so much. So love those.
One question on Nina. Why did she get an ultrasound of her lower extremity? That's not a normal thing.
Just to check for any venous issues.
But people do that when they have symptoms of something. So maybe there's a little bit to the story that we're not hearing.
Well, I guess for me, I have spider veins. Just
maybe
things.
she has varicose veins.
Yep.
Maybe there's something on her exam that this physician's seeing. And, the fact that someone got an ultrasound order, that's not a normal test to order. Now, if you go to the concierge doctors, they may order ultrasounds like, you pay out of pocket. You don't go through your insurance companies to look at flow of the arteries and veins to see if you have peripheral atherosclerosis, kind of a judgment if you need to start statins and stuff like that. So, but yeah, that's interesting.
Yeah.
I'd like to know more to that story.
Yeah.
All right. What else?
Interesting. All right. So our next one came from episode 180, which was our Reddit response, tummy tucks. Like what you wish you'd known about tummy tucks. This is a great question. How do you know if you need muscle repair? And would that help strengthen your core? Or could it be a reason you're unable to strengthen your core? I've been told multiple times that in order to combat back pain, I need to strengthen my core.
Yeah. So Carrie Childress 6257, very good response. Yeah. If you think of your torso as a cylinder, and part of that cylinder is opened up without strength, it can kind of radiate back to your back. Mm-hmm. Your whole kind of anatomy is disjointed. If you think about from a chiropractor standpoint, you're not perfectly set up. And that's why you can have this distribution of back pain when people have rectus diastasis or splitting of the muscle.
Well, and people often, are told by let's say their Pilates instructor that they will fix their rectus diastasis, or that they will, fix something with the core. And Dr. Martin, What do you tell those people?
I mean, I would love for that to be the case, but it's not going to happen in most cases, in almost all cases.
So what is the solution?
It's going to be a diastasis repair. You have to bring the muscle back to the midline. Pilates, these are vertically oriented muscles. There is no way with Pilates to bring those muscles back together once the fascia in between those muscles has been
actually torn.
Yeah. It's not really torn, it's stretched out, but you get the idea. It's not a hernia, but it's as close you can come to a hernia as possible. And once that's denuded, once that tissue is not high quality or quality tissue, that you're never getting it back without a surgical correction.
Yeah, and we tell patients this. So we do have a lot of patients who come in and ask this same question, like, are they going to be able to strengthen their core after surgery? And we tell them, like, potentially. However, like, it doesn't mean your back pain is going to go away. Now, will you have a greater ability for the abdominal wall to contract in a more correct anatomical position? Yes. Does that mean it's going to fix your back pain? Not necessarily. We've had patients who it has helped their back pain, and we've had patients who've had no change in their back pain.
Anecdotally, it seems to help, but there's not like tons and tons of data. They're not doing like full on, physiologic test on people afterwards. But in our experience, it tends to improve both the feeling of core strength and also the lower back discomfort.
Yeah. But muscle repair alone, like a rectus diastasis repair, is not your entire core. So that is not the reason you are unable to strengthen your core.
Right.
Your core goes all the way around you. I mean, like literally the muscles, even that come in from your obliques, go in multiple different fiber firing directions. So it's not just about strengthening the direct midline of your body. You still can add stabilization to your QL, to your obliques. Like those things can be strengthened independently of strengthening the exact like middle of your abdominal wall. So someone telling you that that's why you can't strengthen your abdominal wall is incorrect, or strengthen your core, because your core is literally all the way around you.
So both are true. Like you can go to the Pilates class and they can strengthen your obliques
and improve your stability.
Yeah, it can help with, strength overall and stature and all that kind of stuff. But yeah, for sure, unfortunately, a rectus diastasis that's at least 2-finger needs a surgical repair. There's no way around it, unfortunately. You can live.
That doesn't mean it's going to fix your back pain.
Yeah, you can live with a rectus diastasis. You can have functional kind of life. You can do exercises. You can mountain climb and ski and do all these kind of things with a rectus diastasis. But it is helpful. And in our experience, anecdotally, people do get a decrease in back pain. But that's obviously clinically specific, clinically dependent on what their back pain is caused from.
Correct. Yeah. If you have like an impingement or something, it's not going to.
No, it's not going to make any difference.
Not going to fix it. But yeah, great question, Carrie. That was a really good one. Thank you so much for listening. Yeah. All right. So this is the one, Dr. Ryan. Nils going to put the picture. So this came from our video that was titled, this was not a podcast episode. This was just a video on our channel at Jason Martin MD on YouTube. Face tight versus mini facelift, or both, was the name of the video. And this Chrissa Mormon 2755 asked. Morim. She had both procedures and none of them took care of the marionette lines. Yeah. Why, please?
Because she didn't want me to take care of her marionette lines. That was half the issue. So this was a patient that came in. I remember this patient very well. She really needed a face and neck lift.
But it was in that time that we don't talk about.
The C word.
C time.
We can't use the C word.
Yes.
So but ultimately she wasn't going to go to the operating room. She wanted something less invasive. She said that to us straight up. She goes, I wouldn't even go to the operating room. So what can you offer me? I said, well, we can do a full face and neck lift under local anesthesia, but that's kind of stretching it. She goes, I don't want that.
She didn't have the downtime. Her kids were all home from school. She had no downtime to recover.
Part of it.
Yeah, that was the bigger issue.
So she really wanted her jawline better, and specifically underneath her chin.
And she knew that, the recommendation was a facelift.
Yeah, that was 100% what I told her. And actually, not that I've watched that video in a while, but I think if you go back and watch that video, I think I probably said that or alluded to that. But it doesn't matter. It's a good question, by the way. So in reality, what we did was face tight underneath her chin to take out some of the fat and tighten the skin. And we did a little small.
Improve the jawline a little.
Yeah. Did a small mini facelift in the office, all under local anesthesia.
She did her facelift in the OR a year later. So I think you might be thinking of a different patient.
I'm thinking of a different one.
This patient, a year later, about a year and a half later, kids were back in school.
I'm thinking of a different one. Yeah.
Kids were back in school. Then she did
we did face tight first.
Yep. About a year and a half later, she came back and did the
and then she wanted
in the OR.
Right. And this patient wanted her jowling better, and that's what we did. So she wanted more of a mini procedure. She didn't want a full. She was also young, this patient. And yeah, I mean, the marionettes did not go away completely, and she was totally fine with that. We talked about it beforehand. Secondly, you can't, in all cases, get rid of marionettes that are deep. That patient was young in her early 40s.
You may not want to because it's going to result in a very unnatural appearance.
A distortion, yeah.
That wind-blown flat lips, you pulled too hard.
Totally, yeah. And so the marionettes, like they're deep, okay, especially in someone who's younger in the early 40s, late 30s, deep marionettes, you would have to pull so unnaturally hard to really efface those out. So the idea would be to do a natural face and neck lift or a mini facelift on someone who's younger, maybe do some fat injections, which that patient now that what Amy corrected me, we did offer. She didn't really want that.
No, because she didn't want to look.
She was perfectly happy with the results.
Altered.
Yeah.
Yeah.
And then the other one is same goes with this. I know it's not with this question, is the nasolabial folds. Actually, it's hard to efface out the nasolabial folds. You just end up looking simian.
Well, and I think that's really what she meant.
Yeah.
Was not. I don't think she meant marionette lines. I think she more meant when you look at the pictures. I think that's really more what she meant was the nasolabial folds.
So for that patient specifically, the nasolabial folds would have required a full facelift, which she did not want.
Well, and even then, she has just heaviness there. That is just her. That's how she looks. She likes that. She didn't want them to go away.
She didn't want to change her facial features at all. But you can nasolabial folds. You can make a difference on them, but you have to carry the incision up a lot higher. You have to do a lot more of the deep foundation SMAS work. It's a lot more involved, and that's not
then you have to be careful about not pulling too hard.
Yeah.
Because once you flatten out those lips and your lips don't have the natural shape to them, that they've been pulled too tight and flat or kind of pulled outward, it's a very unusual look.
So I love this question. I appreciate the fact that you're looking at this and seeing things you don't like or do like and stuff like that. We love that. That's great. Actually, face and neck lifts, which we do all the time, it's one of my specialties, should be bespoke to what the person wants, not to exactly what we, like you, I, or whoever may see. And when I plan these surgeries, I really take into account what the patient wants, and I try to add some of my special sauce, but stay within that range. And that's really important, because if you go in and say, hey, I mean, that's why we have long discussions. Hey, I don't mind my nasolabial folds, but marionettes want those a little bit better, but definitely my jawline. I'm getting premature jowling as a younger person. Then you want to address that. And there's been so many cases I've done where I could have done a full face and neck lift and the patient wanted a mini,
or we recommend a brow lift and eyelids and other things. And they're like, nope, don't care about my eyes.
Don't care about my brows. Yeah. And that kind of stuff. And it definitely affects the results when you look at it. So the results, if you go look on my website, the ones that are like way transformative to the face and neck, we probably did a lot of stuff. Full face and neck lift, brow lift, upper eyelids, lower eyelids. So, some of these lesser transformative procedures for outside looking in, I'm like, oh, was that worth it or not? Well, it depends on what the patient wanted. The second thing, the reason why that video was so interesting is it really just shows you what face tight can do, period, on a relatively younger person, and then what a mini facelift can do, period. And it shows you on the same person. So you can see before the face tight, that's the result afterwards. And then from there, what a facelift does, there's not many chances you get to see that if you're kind of deciding if you want face tight or a mini facelift.
And she's also 40. I mean, so she doesn't want to look altered. She wants to look very natural, and she knows she's going to need another facelift.
So by the way, I'm sorry I got confused in that because I wasn't looking at the thing.
Sorry, I don't have the picture pulled up.
But I thought you were talking about the patient we did face tight and a mini facelift who really needed a face and neck lift, who was late 50s.
No.
And then when you were talking about her kids, I was like, what are you talking about? That was interesting. So yeah. Okay.
So thank you. That was a
great
question. All right, we're going to take a quick break, and then we're going to come back with a really good text and a couple of more questions on our episodes.
Awesome. Thank you.
And we're back.
We're back.
All right. So let's get right into it. So this was going way back in the Wayback Machine from episode 63, breast reduction.
So is this comment recent, or is this from an old comment a long time ago?
No, this is a recent comment. These comments have all come in since our last episode.
Oh, I understand.
Since our last questions from listeners. So this is on an older episode, but it's not an old question. It's a new question.
Got it.
I don't ask old questions.
Maybe. I mean, you know.
So
there's a lot of
this one is from
questions.
RJNSN5121. Thank you very much for educating me on the topic. Please tell me where to find tips on how to train myself ahead of time to sleep face up. I have been a side sleeper all my life, and that is a big concern.
Oh, man. I don't know.
Where do I find information on the process of out-of-town patients? I appreciate your help. So to answer the second part of that first, if you became our patient, we would give you all that information, and that's going to be the same for any doctor you go to. So that aside.
Yeah.
So how do you train yourself to sleep on your back or to sleep, in that position? I would first say, I don't know that I would spend a lot of time trying to do that before surgery, because you don't have to sleep like that forever. So it's not like you need to train yourself to do this for a long period of time. And after surgery, you're going to want to sleep in that position because it's going to not be comfortable to sleep on your side. So it's not going to be as much of an issue as you might think it is. Get the pillow system I recommend. Those are my tips. But like trying to train yourself ahead of time, I wouldn't spend a lot of time doing that.
Yeah, I agree.
Yeah. After surgery, you're uncomfortable, you're stiff, you're kind of propped up anyway. It's going to come a lot more natural to you. Now, you can do it. We had a patient, oh my goodness, way back in the day when we were only in Aspen, who literally trained herself to sleep on her back with no pillow, flat on her back, like she's laying in a coffin.
Like she's a Navy SEAL.
Yes, because she had heard
That's awesome.
that, it prevented wrinkles. And I'm like, okay. I mean, like she's like, I don't even move.
Oh, I believe her because I sleep with a pillow over my head. My wrinkles have gotten so much worse around my eyes than the pillow.
Well, but have you also aged since then?
No, come on, Amy.
Gravity has affected you, sun damage. Do you wear sunscreen?
I'm doing all the Dave Asprey stuff. I haven't aged one bit.
Exactly.
No biological aging.
He's not a good example.
I'm joking.
Like, yeah, I know. That's what I mean. Like, he's a terrible example.
Amy, before someone has surgery and gets your pillow system, do you suggest they try sleeping with it just so they know what to expect after surgery?
I tell them to set it up and to try it out, see what feels good.
How you're going to be, so you kind of know what you're doing once you get back and you.
Well, mostly because there are a lot of pillows and people don't need to be as upright as they think. So,
Gotcha.
That's what I would say. Just like the day before, set it up so it's ready for you when you get home from surgery. Lay on it, kind of move it around, but you're going to move it around.
You should create your own pillow system and go on QVC with your red glasses.
So many. Yeah. There's so many that exist on
Amazon. And your flowers in your hair.
Yeah. But really, more than anything, I would say don't spend. I mean, that's the least of your worries after surgery.
Yeah.
Like, it's really fine. You're not going to.
It's a good question.
It is,
but it's. Yeah. You'll probably take some pain medications that'll artificially make you sleep a little bit. But like. You'll get through it.
Yeah, you'll be fine.
You'll be fine.
Yeah, I wouldn't. My point more is just don't worry about it. Yeah. So okay. I will send you the link for the pillow system.
What else?
All right. This was another one that was not this was not a podcast. This was just a video on YouTube. Arm lift options and alternative treatments. And I love this. This is from Lupe Adame PY4.
P4Y. P4Y. P4Y.
I am very
Y
dyslexic.
Before P.
P4Y. It looks like pay. I would love to have the surgery. I take Eliquis. Maybe cool sculpting? It's embarrassing to have huge bat wings. So this is a great question, Dr. Martin. What would you recommend for someone who is on Eliquis and can't stop? Let's just, for sake of argument, say they can't stop.
External treatments.
I wouldn't recommend cool sculpting on the arms, especially if you have...
I wouldn't do cool sculpting, but I would do external treatments, maybe for skin tightening, some ultrasound-based technologies that maybe reduce the fat a little bit.
Yeah, but just know that those things, if you watch our episode all about skin tightening technologies, these external treatments are maybe going to give you 10% improvement.
That's better than nothing.
It's better than nothing, but it's more about the expectation. And even some of them taking Eliquis, you still may bruise, especially from something like, I don't know if they would do cool sculpting on someone on Eliquis because the risk of bruising.
So Eliquis, the common reasons are AFib, atrial fibrillation, maybe history of DVT and pulmonary embolus, history of clots, things like that, maybe history of cardiac event or heart event. So most of those reasons, there's no doctor, like primary care physician or hematologist, et cetera, who's going to be okay with you stopping it for elective surgery.
Who's going to bridge you for elective stuff? Yeah.
But every now and then you get someone who has rate-controlled atrial fibrillation. They're on Eliquis prophylactically. You could probably get the doctor to agree to stopping it a couple days beforehand, and maybe you could do something a little more invasive.
Yeah, like some lipo or something that's not like incisional, like long incisional. Yeah. But Lupe, I hear you. I mean, arms are something, and we have patients who have been at a normal weight their entire life, and they just have those genetic arms, like those thick arms.
With loose skin, it's tough. We're with you.
Yeah. So, definitely get some consultations for the external things, but keep your expectations in check because they're not going to be surgical results.
Yeah, 10% is the best case scenario.
Yeah. All right. So this was an email, and
this is so amazing how long these.
I know, and I love this.
Are these emailing you, or are these on our channel?
No, these are emails. That's why it says email. These people emailed me directly.
It's crazy.
Yeah, that's why it says email. Yeah. So they asked me not to.
It says email at the bottom. Yep. Okay.
She asked me not to use her name, which is totally fine, but she did say that she hoped that we use this on the podcast. She said, "Thanks so much for the awesome podcast. I have learned so much from you and Dr. Martin. I have a question I'm hoping you can help me with. I'm planning on having my first breast augmentation in a few weeks.
Nice.
I really want a very natural look and am thus choosing an under the muscle placement. However, I also love lifting weights and have been doing so for many years. I especially like doing pull-ups and push-ups and have recently heard that some surgeons say that after submuscular breast augmentation, you should never do any kind of direct chest work ever again.
Ever again.
And that doing so...
Don't ever use your chest again.
And that doing so may cause your implants to migrate laterally and look a lot wider and thus less natural. That really bums me out as this is something I love about blasting out pull-ups in the gym. Very empowering.
Yes, I love pull-ups.
I know you and Dr. Martin are very into fitness and weightlifting.
Hell yes.
Can you give me any advice on navigating the love of weightlifting versus wanting a very natural breast augmentation? If you're able to point out specific exercises, angles, grips, etc., that are problematic versus less problematic, that would be amazing. Love this question. I am an NPC bikini competitor, so obviously I lift a lot of weights. And I will tell you this, that most women in the NPC have breast augmentation and they all lift a lot of weights. And there are women doing pull-ups. There's also women that do CrossFit competitions.
Whatever crazy competitions that Amy does, all their breast implants aren't out over here.
No, they are not.
So,
however,
that's a small subset, but I can tell you from our experience at these competitions.
Yeah. The times when we do recommend that women go above the muscle, specifically in like the competition world, are women who are in the extremely muscular divisions. So think figure and above. So if you're a figure or a women's bodybuilder or women's physique competitor, those women get like striated chests. I mean, they part of their routine is to flex their chest. So they need to be able to flex in a different way. Now, I love that your doctor told you that you're going to somehow make your implants wider after surgery and not look natural. I mean, like, what is that?
I wish I had her name right now. I would give her a hug.
Now, it is true. If you start doing things after surgery, immediately after surgery, before you're cleared,
you definitely mess things up.
Yeah, you could displace the implant from the pocket, but that isn't even necessarily a weightlifting thing. Like that you could do that doing other things. Yeah. There are definitely things, and I talk to a lot of our patients about this, like changing your angles and changing the grip that you do things after surgery for comfort, absolutely. But this does not mean that there are not women who do CrossFit competitions, busting out hundreds of pull-ups in a row, who have perfectly natural looking breast augmentation and their implants are in the pocket.
Yeah. We always give deference to surgeons you've seen, but I can tell you in our experience that I don't agree with this at all. Yeah. And secondly, if that was the case, we would have a lot of hesitance of putting it underneath the muscle because we want people to do push-ups and pull-ups, and especially where we are in Colorado,
and flies and other things.
We encourage our patients to lift weights.
Climb
I would
rocks.
never put an implant underneath the muscle if that would all of a sudden be destroyed, flattened, lateralized from you doing things. So I think you should feel very comfortable with that. Also, putting in a normal to natural size implant is going to really lend well to that. So you're not going to really distort the muscle too much with the implant underneath.
Or be outside where the muscle sits. Now, if you were, and she did give me the size that she was kind of looking at, which is not important because again, sizing doesn't matter. It's person specific. But if you were like, yeah, I want to, blow it out and have the world's biggest implants, like they're already not going to look natural. So again, like that's also, they're already lateral from just the size.
Right. And Amy's way better at this. She has better technique than I do, but just like a pull up alone, you can do a front grip or like under grip, a chin up. And under grip is more your biceps. I'm really good at that one. I have stronger biceps.
And women are too. I mean, most people are better at chin ups than pull-ups.
I mean, this one, it's like, oh my God, what happened? So you can find different grips. And by the way, you're like, just from a body perception standpoint, you'll know when that's a little bit off. Your body will tell you, you love to work out, you're connected to your body. Don't worry about it. Right.
But also don't try and go back to it too quickly.
Yeah, that's the other thing too.
I would say 12 weeks.
Yeah. And
minimum.
We encourage people at least 2 months.
Before doing direct chest work. I mean, I mean direct chest work.
Yeah, direct chest work. That's what I was talking about. Yeah. So you have to, you'll do arms, you'll do legs, you'll do core, but avoid the chest for about 2 months.
And some back exercises too. And I think that's probably what surprises women more than anything. And a lot of women too, I talk to about changing how they do tricep movements right after their surgery, because you'd be surprised if you're doing like rope tricep extensions, how much of your chest actually gets engaged. So you have to be careful for those first 3 months.
Right.
I'm
laughing when I do that. I really, really try to focus on my triceps, and ultimately I get tired, and before you know it, you're
pushing them down with your chest.
You can feel your chest moving it.
Yeah.
You know what I'm saying? Because you're trying so hard to focus on those triceps.
Yeah.
That's why it's better to do I don't know how you feel about this, but like sitting down and doing tricep extensions with heavier weights for me, because it's kind of primarily focused on your triceps, and you can't let it go because it's going to hit your head.
Yeah, I would not recommend that after breast augmentation. But I mean, for general strength, yes. But that's one that I would say don't do overhead tricep extensions for a good 3 months after surgery. Because again, you're stretching that pocket and then it's just, I would not recommend that.
Yeah, that would be pretty bad.
Yeah. So, specific exercises, I think anything that doesn't feel awkward is going to be okay. But a lot of us who lift weights are okay pushing past awkward, which is why I would say don't plan on doing any direct chest or most back exercises for up to 12 weeks. And like Dr. Martin said, you can still do arms, you can do core, you can do other legs, like those things you can do, but letting that pocket fully heal, once it's healed, to get the implant through your own muscular strength to migrate out of the pocket.
I've never seen it.
No. I mean, you can have an implant that moves out of the pocket, but it's not because of the exercise.
Not that way. We've, had one where like kind of went superiorly, but that's not
or drops
laterally.
out, like bottoms
drops down.
out.
Yeah, but like not.
And these were not in bodybuilders. Like
Yeah.
the times we've had implant go out of the pocket, it's not from somebody doing push-ups. It just isn't. Like those things, there can be fluke things that happen with that, but it's not direct. It's not from doing push-ups. And again, push-ups, you can be back to those probably more quickly than even pull-ups because push-ups really shouldn't be directly chest. It's like a lot of muscles.
Yeah,
So,
I mean, you bring your elbows in and do tricep
like a
push-ups,
tricep push-up.
which are always good.
So yes, just go to NPC online and look at all of the female competitors in every category, and you will see that probably 90% of them have breast augmentation. And those women lift weights more than the population at large. So
When you say at large, is writ large the same meaning as at large? I've always wondered that.
Yeah, I think so.
Okay.
yeah.
It's just another way of saying it.
Is that like a legal term, like writ large?
Writ large, yeah. Isn't that
Or like an old English term?
Yeah.
Okay.
Yeah.
Awesome question.
So thank you so much. And I hope that you're recovering well now at this point and feeling really good. So, all right. This was a text from Robin.
What?
This was a text. So
She texted this up from a phone?
yes, texted this from a phone. So if you want to text,
Who are these people?
again, the text is 303-321. No, that is our phone number.
You can call for a consult.
Right?
Yeah.
I'm literally looking at the piece of paper and saying a different number, which is why I have the paper.
303.
630-9038. And you can text
Here,
like Robin
let's
did.
put the number right down there. There you go.
Okay. So this is great. And there's 6 or 5 kind of individual questions. So bear with me, Dr. Martin. I'm going to get through all of it and then we'll go through them again.
Yeah.
So this is from Robin. For Q&A on Beauty and the Surgeon podcast. I love that she started this way.
Love
Hi,
it.
Dr. Martin and Amy.
Hi, Robin.
I am considering a redo of saline breast implants that were implanted in 2002 and a mastopexy, which is a breast lift. I have rippling with the current implants when I bend over, and the right implant has always been what I consider too close to my armpit. I have a consultation with which, again, we talk about saline implant placement and that they did tend to go through the armpit and we don't like that. So I'm wondering if that's what was the case because they do sit too close to the armpit.
Yep.
I don't know that for sure, but with a saline implant, it kind of makes me think that they did.
Maybe.
Maybe. I have a consultation with a board certified plastic surgeon with the following
Awesome.
feedback. I have lateral displacement of breasts, right and left, right greater than left. The current implant size is too large for my body type. I need a lift. She will only use silicone implants in her practice as she feels they are far superior to saline because saline implants expand. I will need a pocket-sized surgical reduced. Yes, if the implants are too big. The following questions were addressed in my consult, but I would like a second opinion from you.
So real quick on the reduction in the pocket size, a lot of implants.
Well, that's her first question.
Okay, let's go ahead.
Yeah. When surgically
I should
reducing,
actually read ahead. Go
when
ahead.
surgically reducing the pocket for smaller implants to fit, will this impact my ability to lift heavy weights and or limit the type of upper body movements I'm able to perform? I understand there will be a period in which I will need to limit upper body weightlifting, but my concern is I will be limited forever unless I want to risk widening the pocket over time. Did these women see the same doctor?
Yeah, I know.
So she's worried though about like when you pull that pocket in, which I'll let you address, like how you prevent that.
All right, so
let me just get through all these.
oh, you're gonna do all
Please.
the questions,
Yep.
okay?
And then
okay.
we'll go back.
Gotcha.
How often will I need to get an ultrasound or MRI for the silicone implants? Amazing question. How great is the risk of complications of a redo surgery compared to the initial surgery? She's 59 and healthy, so definitely not the same person as before.
Wow.
I've gone 22 years without any significant complications related to the implants, so is it worth the risk of having a redo now?
Right.
Would a mastopexy or a lift alone benefit the lateral displacement or only change the vertical drooping? Okay.
So many, like this is such a layered, yeah.
Yeah, so these are all great questions. So Dr. Brown, let's first talk about the pocket because that was really her first question.
Okay. So when you do an implant exchange and you go from a bigger implant or a wider implant, the implants in the old days used to be less projecting and more wide. I don't know why. Maybe that's just the way they wanted them or made them. And so Robin clearly has a wider implant that's also displaced laterally or to the outside. So you're going to have to narrow down that pocket. Remember, the implant's in a pocket. You can't put a smaller implant in and then not change the pocket around, all right? Assuming you're using the same plane, the same area, because the implant will fall over, especially when she lays down, will end up in her armpit. So pocket revisions can be very difficult. They require suturing material and sometimes grafts. There's a lot of different grafts out there. I use them all, but that gets into the weeds. And that's something you should talk to your surgeon about. So if you do a pocket revision, it's really important that you take a break for a while in terms of range of motion and definitely in terms of weightlifting and all the stuff you like to do.
Listen to the question before, 12 weeks at least.
Yeah, you need to give yourself an ample amount of time to heal that repair. Because, of course, any aggressive movements, even if you weren't weightlifting and you fell down, you're walking your dog and it jerked away.
Pulled a really heavy car door shut.
We've had everything. Airline, like on the bags overhead.
Right, you're trying to catch a bag.
Down, that comes down, tripping over something, falling down, putting your arm forward. All these things can really ruin the repair of that pocket. So if you want to, in general, downsize and do a lift, which is what a lot of women are coming in our office doing these days, because the implants that were placed in the late 90s and early 2000s tended to be pretty large and probably too big for their bodies. At least now. So they're coming in, they want to downsize. Almost always a smaller implant's going to be more narrow. And so you have to create a snug pocket. And that's what a pocket repair will do.
And doing the lift, you have the benefit of being able to kind of pull that tissue in around the new pocket to further reinforce it.
Right. So a lift can narrow the width of a breast, the vertical portion of a lift, and it also can shorten the breast as a measurement from the base of your neck to your inframammary fold, the base of your breast. So it can actually lift that fold. So it can narrow the breast and shorten the breast, which is what most women need when they have droopiness.
Yeah. Definitely listen to what we said about weightlifting on the question before this, because we covered that in detail, which is why I put this one after.
Yeah.
So listen to our recommendations there. You'll get back to lifting again. You're not going to stretch your pocket out as long as you've given it an appropriate amount of time to heal.
Yep. MRI, ultrasound?
So per the recommendation of the manufacturer, you should get your first MRI within 5 years of implantation. Ultrasound, we usually only have women go for ultrasound if they're having a complication. However, there are new 4D ultrasounds that can that offer an alternative to MRI. They're really cool. They're not covered by insurance, but they're a great way to monitor the implant. So with less, risk of squishing the implant like a mammogram, still going to recommend that you get mammograms as recommended for whatever risk stratification group you fall into.
Mammogram and the MRI per the FDA is the gold standard.
Yep. And when you get your implant exchange, you will now be given by every breast implant manufacturer, they will actually give you a pamphlet or have you sign and initial all of these things that you understand that MRI is the gold standard for testing, how often it's recommended, all that good stuff. So your doctor will go over that with you as well. They should have.
It should have.
Well, and even if they didn't, it's in the pamphlet. I mean, they should. You have to sign it. You can't have the implants without signing it.
Right.
So
let's talk about risk and complications after a redo. Definitely higher than a standard breast augmentation, but not exorbitant.
We do it all the time. That's with any redo surgery, not just breasts.
Also, adding on a breast lift makes things much more complicated. People tend to approach this kind of with a laissez-faire attitude. It's one of the harder surgeries I do, which is the breast implant revision, narrowing of the pocket, and a breast lift. So you need to go to someone you feel comfortable with that has experience with this surgery. Now, it's going to be better. Your results will be better than most likely what you have now.
Oh, for sure.
But it's a complicated surgery because basically what you have to do is do the implant exchange, narrow the pocket, and then rebuild the breast around
the new implant.
Which is probably going to be in a different position, obviously, than the old implant. So a lot of your markings in the preoperative area have to get changed. We do something called tailor tacking, et cetera, et cetera. Breast lifts can be done in two different ways. We have a great episode on breast lifting. I don't know. Nils is going to show it. Watch that. You can learn all about it. So you've gone 22 years, no.
Can I say one more thing
Please,
about the redo surgery? So like you said, it's definitely just a much different surgery than your first surgery. Just a breast augmentation alone has one tiny little incision at the base of the breast, or maybe they went in through your armpit with saline. I don't know. Hopefully, or went in through the umbilicus. Who knows? They used to do saline
tuba?
implants. Yeah.
Oh my God.
Right in 2002, it could be. That was
It
when
probably
it was,
was a tuba.
It could have been, which is could be why it's sitting weird to the side. Either way.
Robin, text her and tell if it was a tuba. It probably wasn't.
Yeah. Or through the armpit.
Yeah.
Either way, now you have a surgery that has an incision, at least all the way around your nipple and areola, and a vertical incision straight down the breast. Vertical. And probably if you had an anchor, they might revise that as well. So you've got a lot more incisional area. You're also having the risk of additional complications or compromise of the nipple and areola sensation, all those things. So yes, are there more risks? Yes, but it's not necessarily the risks. The risk of the lift is the same. It's just anytime you go back in an area and do surgery again, it kind of, you're doubling down a little bit on some of those things, like having skin numbness or skin changes, all those things. But don't let that dissuade you from doing it, because getting a breast lift, especially at 59, like if you've had these implants for 22 years, as Dr. Moore was just getting into, I think the complications are worth the risk of having a redo.
That's what I was going to say. So 22, of course, you don't have to do anything. I mean, you're functional.
Right. They're not deflated.
They're not deflated. You have something reasonable, at least something you can live with, but that's not our ethos. That's not what we think. As long as we can maintain the risk, keep you safe, and make it a lot better. And that's pretty much most patients that come in. And even the ones that are pretty bad off, I can definitely make it better. I just can't make it perfect, but I've done that. I've had some really, really bad breasts come in.
Well, tomorrow we actually have that's exactly what we're doing tomorrow. And it's a complicated case.
Why'd you remind me? Okay.
But
now I'm going to wake up at 2 a.m. and it's like, oh, Amy said this one's complicated.
It is, but it's nothing you can't handle.
I know I can handle it.
He's like a Jedi over here. And she also has had her implants for more than 20 years.
Yeah. And by the way, you've gotten your investment out of it.
Yes. Well, and that's what I was going to say.
You got your return on your investment, 22 years.
The benefit you'll get of changing out your implants, I mean, your surgeon is correct. Saline implants are far inferior in the feel, in the look, in the everything. And you've had rippling, for who knows how long you've had rippling. It may not go away completely, but it will be improved with silicone implants. They're going to feel more natural. They're going to be softer. They're going to be more the size you want. I mean, if you said, well, I had these done 2 years ago, is it worth going in and doing it again? Now I'd be like, well, wait, give it a little time.
Yeah.
Wait till maybe something's gone wrong.
But 22 years, totally different story.
Exactly.
Implant technologies are way better than they were 22 years ago, both for saline and silicone. Silicone is superior, period. But saline's not a bad option. If that's really, really what you want, you could just say to the surgeon, that's what I want. Saline tends to ripple more because even if you overfill it, you can lose a little bit of fluid over time, and they tend to
they just don't feel as good no matter what.
And so the silicone that's cohesive, and we have great episodes on that, keeps its shape, its form better. So you can have more projecting implants, better shapes, et cetera, et cetera.
Yeah. Would a mastopexy alone fix this?
No,
especially with a saline implant. The risk of having a saline implant rupture or be punctured during a mastopexy, you don't want to do that. If you're going into that pocket to fix it, you need to change out the implant.
Yeah, there's no reason to go to the OR and do a lift if you're not going to fix your breast or your implants.
Yeah, especially with 22-year-old implants.
I love this last sentence. So I enjoy your podcast. We enjoy you, Robin. And the information helped me go through my facelift 6 months ago. We love that. That's exactly why we made this podcast, is for people like you to go through surgery and feel confident in what you're doing, especially with the facelift, which was one of my favorite surgeries.
Yeah.
So,
I mean, so you've done the hard stuff. You got the facelift.
Yeah.
Get your implants
fixed. Man, you're going to be a new and improved person. I'm getting a little jelly over here.
And you're relifting weights along with our nameless emailer.
Yeah.
You guys are going to be crushing it in the gym.
All right.
Yes. So that was it.
That's pretty good.
I loved the updates. So please, my email is always in the description box below. So if you want to email me, it's there, and you can text me. You can just leave a comment on this video. We love interacting with our listeners. And it also, I feel like these are some of the most educational videos we put out, because it gives us, we can ping pong. People get to the inside sauce. When we talk about things that are unusual.
Yeah. Well, I mean, but inside baseball, we talk about this all the time about our cases.
Yes.
And I come in with, my extreme confidence. Amy's like, I don't know about that. She kind of challenges me a little bit. Yeah. That's good. I love how these listeners elucidate what they're feeling, and they put this in these long, well-written responses and emails.
I love the long emails.
Yeah. I didn't even know that existed. I mean,
emails?
Yeah. Well, that's funny. I don't send long emails, by the way. Yeah, ever. And it's after the second paragraph, I'm like, and I'm done. Thank you. I don't care where I ended it.
Oh, I love the long emails.
No, but I love the fact that you spent the time and emailed us and texted Amy or whatever. So that's wonderful.
And Nina, number 2, I love that you sent our podcast episode to a doctor.
And he definitely did not watch that,
No.
he or she.
No, but hey, you know what? It got you to where you needed to be with him, and that was that you needed to find a different surgeon.
Right. Yeah. I love that.
Yeah.
I, for one, love that kind of stuff. I will watch anything. I'll read anything if people send to me, that kind of stuff. But that's the way my brain works. Most of these professionals, there's a lot of ego involved, and they're not going to listen to some Yahoo on Beauty and the Surgeon talking real truth. It's just not going to happen.
Yeah. All right. Well, our next episode, we have something extremely special. As I said in the beginning, it is our top 5. You get the top 5 moments of 2024. You
Yes.
also get the Nils mashup, and then it's January. And what is time? Seriously.
Oh my God, it just keeps going.
It just keeps going. The train keeps rolling.
Nils, have you started your mashup yet?
Oh, I keep a list.
Okay.
And every episode, anytime something makes me laugh or I like something, I put it down. But then it becomes
It's
what
hard
do
to
I
make.
It's
the
hard
cut.
to narrow it down.
Sometimes
Yeah.
when I'll pull them all and put them in,
Yeah.
like, oh, that's 30 minutes.
Yes.
I gotta, so then it's about, picking my favorite children. And that
It's
can
kind of like in memoriam with the Oscars. You can't fit every person that passed away in there.
Right, you got to leave some of them out.
Yeah. So I got to get started on it anyway and start getting that together. So you
Nice.
guys give me your picks.
The other thing that's coming up in 2025 is our 200th episode.
That's true.
Yeah. And I got a crown for the 100th episode. And Nils, I would like a crown again.
I'm
And
gonna wear
I
it.
feel like I was promised a car at some point.
No, you get a car. I'm going to get a tuxedo. I'm going to wear a tuxedo.
Or a ball gown. I was going to say something else, and now I can't remember what it was because that's just how the mind works. But yeah, whatever it was, I bet it was good.
Yeah.
Oh, I know what it was. My favorite moment on the podcast of all time, still the 10 sheep.
Yeah.
Just 10 sheep. Feed them, give them water, keep them fed.
What was that? I don't even remember what that I said that.
The
Right?
amount,
That was
yeah,
in
you did.
reference to something?
We were talking about the amount of cells in the body, and you're like, this is why cancer is like impossible to treat.
Yeah, exactly.
10 sheep.
My favorite is still, I'm a man.
I'm a
That
man.
was
I guess you are.
with no context. in the
Yes,
episode.
because I had not said the title yet.
It just came out of nowhere.
Thank you.
That's when you know that I'm never going to be the true talent on any show. I just yelled it
That
out.
was so perfect.
Yeah.
I love it.
Follow us for more real good influencer tips. All right, everyone. Thank you so much for listening. Super excited for you to come back and watch our top 5. It's my favorite episode of the year. I cannot wait. Leave us a comment below. Like us. Follow us on social media. Do all the things. You are amazing. The listener episodes this year were off the charts good.
Yeah, we love the two Ninas too.
Yes.
Okay.
Bye.
Bye.